This is quite a bit of information, so I will try to be as brief as possible. The most relevant disclosure is I have a strong opinion about this, but I may certainly be wrong and eating crow in some number of years. And hopefully, at a minimum, we make it better than it is now. So we'll talk about understanding and remembering really the cone of economy. I think we need to forget lots of what we have been taught and think of it in a new way. And then we need to try to objectify normal alignment so that we can understand things like Russelli and make, I think, precise alignment targets, right? Personalized medicine is precision medicine. The development, right? And we come from apes. Apes have a globally kyphotic spine with a very low pelvic incidence, which is why they stand like they do, because you cannot have upright posture. We develop in kyphosis in utero, right? And then you have primary sagittal plane curvatures and acquired sagittal plane curvatures. The primary sagittal plane curvatures are thoracic kyphosis and sacral kyphosis. The acquired are lumbar lordosis and cervical lordosis, which come with bipedalism, right? Tummy time, cervical lordosis, then with crawling, you get some lumbar lordosis. Then when you stand upright, you develop your lumbar lordosis based upon your pelvic incidence. Then your thoracic kyphosis balances with a goal of keeping you in the cone of economy, which we will also objectify in a little bit. So this is actually, and I got to change this slide. I changed it in one of my other talks. It's a balance of cervical alignment, not cervical lordosis. I think this is one of the first things that perhaps we need to teach the radiologists, right? I see a ton of radiology reads here that say loss of normal cervical lordosis, when in fact the person is perfectly balanced and their normal cervical alignment is reasonably neutral, right? There's a number of cervical alignments that are possible to be normal because cervical lordosis is tied to your thoracic kyphosis. Your thoracic kyphosis is tied to your lumbar lordosis. Your lumbar lordosis is tied to your pelvic incidence and your lower limb alignment. Ultimately, also, it's not just these measures of lordosis, kyphosis, and cervical alignment, right, which are just shapes. It's also magnitudes of these numbers. So it's not so easy to just say, okay, LL should be this, and this is where we are, because you need to figure out where to put it. And the goal is to get into the cone of economy, right, to minimize energy expenditure when standing upright. And I think for those of you that sort of ascribe to perhaps age-adjusted alignment targets, I think you just got to do one where you nail someone old perfect, and you can see the difference in their comfort. That when you leave them with what I call a subtle flat back and they're off by 15 or 20 degrees, and it's not the gross like, hey, we just discovered pedicle screws flat back, but a modern flat back, that you can see that they can do much better because they are working a little bit just to stand upright. So I gave you a simplified version of the development of the sagittal plane. I think this paper in JBJ is actually very nice, and fortunately, it really dovetails into the means work very well. So the French studied over 1,000 healthy kids. Unfortunately, like to make the study perfect, right, would have been to track a single individual over time, but they got very large groups of different age groups. They lumped it into a thoracic alignment and a lumbar alignment. And then they made the thoracic 3 alignments, right? Proximal thoracic kyphosis, mid-thoracic kyphosis, distal thoracic kyphosis, as well as proximal lumbar lordosis, distal lordosis. What they found, right, was that as you become skeletally mature, pelvic incidence tends to increase ever so slightly. And that is because of the A to P growth of the pelvis in the absence of a change in the pelvic incidence. So it's only 6 degrees through maturity, but I think the concept that through growth it changes, and then what you see happens on the next slide is that so pelvic tilt increases with skeletal maturity. And why is that? Because pelvic incidence is increasing. So as pelvic incidence increases, pelvic tilt goes up. That is important to understand for the adult world, because then you will understand why, if your PI is 70, a PT of 25 is probably acceptable, as opposed to if your PI is 40, a PT of 25 is totally unacceptable. So pelvic tilt increases by about the same degree and pelvic incidence. So that means what happens to sacral slope? Sacral slope is unchanged. That's the bottom slide here, right? Sacral slope does not change over time. The PI is going up and the PT is following as it goes up, as those femoral heads grew further away from a sacrum that is not changing its angle in space, right? Sacral slope would be changing this. Pelvic incidence and pelvic tilt is just hips growing further away. So the growth of the pelvis results in PI and PT change. PI is the sacral pedestal, right, driving the sagittal plane curvatures. So what do we see? Over time, lumbar lordosis increases, but there is rather small, there is essentially no change in the lower arc of lumbar lordosis, right? And this is what comes back later. Now people, Steve Lewis, Virginie Lafarge, the Means group are all saying that that sort of low lordosis arc is irrespective of your pelvic incidence, as opposed to the proximal lumbar lordosis arc, which is related to your pelvic incidence, which is what we see over the growth of the skeleton, right? This is all like confirming the stuff that we have said without this good evidence in the adult world. So PI and LL, right, they drive the proximal curvatures. Then, so what happens in the thoracic spine? And I think some of you that were in Vegas heard me talk about this, that the proximal arc of lumbar lordosis is equal to the distal arc of thoracic kyphosis. Sure enough, that's what changes as your PI changes, the proximal arc of lumbar lordosis changes, and the distal arc of thoracic kyphosis changes. And you can see that proximal thoracic kyphosis T1 to T5 is relatively static across these age groups. So as we are developing our sagittal curvatures, the proximal arc of LL is changing, the distal arc of TK is changing, and pelvic tilt is accommodating your PI. Why do we care about this? There's actually not great studies out there. I got to update this with stuff that's not published yet, but we have churning through. Is that a flat spine is biomechanically not favorable. And this is a FEA, finite element analysis, of sort of subtle flatbacks, right? These are just off by a bit on the left-hand side. And you can see that as the spine is flat and the pelvic tilt is higher, that active retroversion makes a fusion mass want to move dorsal while the spine is forward and tries to move ventral. And that creates shear in the disc. And discs, we know, have a nucleus that's good at compression resistance and an annulus that's woven like a basket weave that is good for rotational stability. But there is no component of the disc that is any good for shear. That's why we get high-grade spondylolistheses and things like that. So as you flatten someone and they become mobile and they stand up and they try to maintain the cone of economy, they will develop shear within the adjacent segments and increase their risk of a proximal failure. My opinion is that adjacent segment degeneration and PJK are one and the same, just of different impressive magnitudes, right? Adjacent segment degeneration, not that impressive, can take a couple of years, even 5 years to develop. And then we say, oh, you got a bad back, you got bad genes, you get a PJK, and then we say it's something different, when I think both of them are probably just different versions of failure through an unfavorable biomechanical state. So if the PI, right, I hope the 5 of you guys know what the pelvic incidence is. The sacral pedestal, we've looked at trying to figure out whether or not the thickness, sort of the distance, actual measured units of the femoral heads from the sacrum has any role in it. The French have talked about it. Zishan looked it all up. It seems to be totally unrelated. So I would encourage you not to consider a research project about that. But in general, we know that as your PI goes up, your lumbar lordosis goes up, and that's what that scatter plot is there. The problem is that those confidence intervals around that scatter plot are quite wide. The scatter, right, is really distributed around that line. What does that mean? Just it's good to understand what this means, because you will see this stuff get presented and you will hear people speak with absolute confidence, but very little statistical background. The scatter is the variance. The R squared is a measure of variance for the regression line. The R squared here is very low because the variance is substantial. If you have a low R squared, it's not a good predictive model. So that R squared is about 0.3, which means that you cannot really accurately predict any particular lumbar lordosis magnitude based upon PI. And how do we think about these things? How do we classify these? I think the first, which was very useful in its time, but I do think it's time to move on, is the SRS Schwab classification system. where he emphasized the importance of pelvic incidence, right? The Europeans had brought it up, but it was really SRS and Frank that have brought it, like, into our vernacular. Some of the problems with this, right, is that it really sought to provide the much desired categories and simple equations. We love categories. We love classifications. How do you classify this tumor? How do you classify this trauma? We love it, though classification tends to lead to misclassification bias. And I think you can see that very clearly here in Frank's classification system, where PI, and notice that his is not absolute value of PI minus LL, which it has now become, which is a 20-degree window, right? In a subsequent paper, someone said, oh, well, maybe it's absolute value of PI minus LL. But Frank says if your PI minus LL is less than 10, you have no deformity. If your PI minus LL is between 20 to 10, you have a moderate deformity. Now, what's the difference between non-pathologic and moderate? I don't know. There's got to be a mild and a close to okay and a not okay. And similarly, SVA. I think we know now that SVA is a terrible measure of sagittal plane alignment. It is okay for you to track any single individual over time, but it is not something that should be lumped together into groups, averaged, and used with any sort of information. It doesn't provide any information. The easiest way to think about that is someone with a really bad flat back who has a vertical sacrum and a PT of 40, their SVA is going to be really low. They're going to be horribly sagittally malaligned. And then pelvic tilt, right? Pelvic tilt less than 20. What we know now, right, is that pelvic tilt is related to your PI, and a pelvic tilt of 25 is perfectly normal for someone with a high pelvic incidence, and a pelvic tilt of 18 is not good for someone with a very low pelvic incidence. But when we go by this, we may say it's okay. And if you see papers still in 2024 and beyond that are classifying like this, talking about PT as if this is the norm, this is not the norm, and it's not useful information anymore. Around the same time, Rousseli was promoting his concept of understanding the importance of the relationship between pelvic incidence and, in his hands, I'm going to sneeze, in his hands, sacral slope, right, and standing alignment, and that the sacral slope is related to a certain spinal shape. He described 4 distinct spinal shapes that later became 5 from only 160 asymptomatic volunteers. And one of the really important things that he espouses is that it's really random. It makes me think of Good Will Hunting, right? That L1 is the UEV in all of our lordosis measurements, when in fact the arc of lordosis may go from T11 to S1 or from L3 to S1. If it goes from L3 to S1 and you include L1 in there, again, information lost, right? You now have no idea what the spine should look like because you're not even measuring maximum measure of lordosis. Limitations, and I think Frank, when this gets presented and Frank doesn't like it, I think it's very reasonable that Frank says it's not 4 or 5 types, right? There's an infinite number of types, and there is a spectrum. I think it's important for the 5 of you to just understand these shapes, and as you see more and more spines and you do more and more cases, you will be able to see all of the shades of gray that exist between a type 1 and a type 4, right? Type 1 is low sacral slope, low pelvic incidence patients, right? I think it's about sacral slope under 25. Almost a vertical sacrum, but with no pelvic tilt. They have a really short arc of lordosis, and then they have a sweeping thoracic kyphosis above that tends to go from L3 all the way to the upper thoracic spine. It's a very distinct shape. It's important to understand that those exist, lest you fall into this trap of the thoracolumbar junction T10 to L2 is 0. That's totally wrong. Totally wrong. Like, think about back to the French paper. Maybe on average, when you take 1,000 people, on average, maybe it's 0, but that's because there are some people that are lordotic and some people that are kyphotic. And if you make it 0 and you make it flat, I can tell you what that's not. That's not part of an arc, right? And Gupta likes to talk about the game of arches. Is totally flat is not a shape. That's a line. And we need arcs and arcs. As PI goes up, sacral slope goes up, pelvic tilt goes up a bit. The apex of lordosis moves rostral, right? The inflection point moves rostral. And it's really these type 2, 3s and 4s, where you start getting that very classic sort of S-shaped curve. And type 2 is a very mild S shape, and type 3s and type 4s are more classic, though type 4s are the highest of high PIs. They're really, I think, complicating factor of this, and this is where we need programs that will help us decide shapes to minimize failure, is that PI of 55 can probably, in lots of, like, PI of 50 can be a 2 or a 3. A PI of 55, you're maybe struggling to make it a 2, but possible, but it can definitely be a 3 or a 4. There are multiple shapes that you can assign to a patient, and that is where some of, and I hate to say the art of it, because we need to remove the art and objectify it, but that's a little bit where the art of understanding what you can do and what to do comes. With the GAP study, I think the GAP study is very important because it understood the importance of realignment in the cone of economy, and it changed our outcome measure. They changed the outcome measure from PROMs, patient-reported outcome measures, which are incredibly complicated, to mechanical failure, which is fairly discrete and hard to debate. One of the really important things to note is that they found that older patients were less tolerant of malalignment. So in one camp, you have age adjusted, where we say as you get older, you can tend to be a little bit more flatter. And then GAP says absolutely not. And that is like a real, coming together of two divergent opinions where, I don't know, I mean, I hate saying right and wrong, but one has to be right. I think you can't have two disparate opinions like that where both are right. That just doesn't make sense. And why, like, how do I think about this is, look at this patient, right? This is a patient from means. They are at good age. This is an asymptomatic 71-year-old, right? They have a ODI is under 20. They're asymptomatic, but their measures by GAP, they're severely disproportionate. And that's all off. And I think the thing to take away from this is that PROMs are complicated and that the biomechanical construct of a spinal fusion is totally different from an asymptomatic degenerated spine. And that once you put metal in, all bets are off against saying things are asymptomatic and flat's okay. And it really becomes a biomechanical construct. That is something that Ferran has been pushing really hard since, I think, the Philadelphia SRS. And then in means, right, sagittal alignment by age. So when I analyzed means, I said take out everyone with any whiff of degeneration or spinal deformity. So no disc height loss, no end plate sclerosis, no spondies, no small scoliosis. When you remove degeneration, what you see is that in the absence of deformity, and that's, again, like, think about this whole idea of, like, when does degeneration become deformity? Nonsensical categories. It's irrelevant. It's a silly debate. And loss of height and loss of segmental alignment is deformity, albeit mild, just like ASD versus PJK. So in the absence of deformity or degeneration, age and alignments are totally independent of one another. And if you think about it that way, the age adjusted alignment papers, which made a regression equation for alignment based upon age only, and they missed the great confounder, which is degeneration, right? Degeneration has a relationship with age, and degeneration has a relationship with alignment, right? It's a confounder. You just can't do that. It shouldn't. I don't think it should have made it through peer review. PI, like, things y'all want you to forget. PI minus LL must go away, right? So these are 5 patients with a PI minus LL mismatch of 10 degrees. On the right is a PI of 80, an LL of 70 with a distribution most of us would find palatable. And they are pretty close to the cone of economy. We like that yellow thing to be green. They're close. But look at the person on the left. That's a PI of 40 with an LL of 30. Why are they so disproportionate? Because your lordosis, when your PI is 40, should be up in the 50s, as opposed to PI of 80 can be peri-80. And that's where the difference lies, because the relationship between PI and LL is nonlinear. And that's why PI-LL in the SRS Schwab classification falls apart. It's not a linear relationship. The distribution matters, right? So this is the same person 4 times with a PI of 50 and LL of 50, but different distributions. On the right, it's down low, and on the left, it's the upside down spine, right? They got a 4-to-1, they got a 4-5 T-lift that's 5 degrees, then they degenerate caudally, then they get some poorly done A-lift, and now they're flat from L4 to S1, and then they get 2 ACRs, and now they have an upside down lumbar spine, and they are out of alignment despite having an LL number that matches because the shape's off. The false type 2 is also important to understand, right? So this was a high-grade spondy fixed with an anterior and then a T-lift. Then I did this. This is probably 10 years ago, I want to say, back when I was like falling into the wash you trap of false type 2s are okay. So look at it. I got her standing up straight. Her pelvic tilt is incredibly high. Then there's like a lot wrapped in here for U5. Her pelvic tilt is high, but she says, she comes in, oh, Dr. Kelly, like, you know, she's bringing me presents. They own a steakhouse. She loved me, absolutely loved me, because she was better than when I met her, but she was not good. So what happens with time, right? She retroverts her pelvis. That fusion mass is going this way. Spine's going this way. Up, here we go. Starting to fall apart. Starting to fall apart. And then she gets the surgery she needs when I fix it and do a PSO. So it means I said I want to describe normal standing alignment. And I had Jeff Hills sort of run amok with this thing, and he looked at everything. And what came out of it really is, and it's fascinating to think about this, is that he made a spline, right? The vertebral pelvic angles, the center of each vertebral pelvic angle. If you connect all those, that spline is the shape, right? And you could try to classify them as Russelli if you wanted. But instead, Jeff looked at each of those components of the spline, each knot of that spline, and makes the shape in relation to the sacrum and the femoral head. He found, importantly, that essentially C2 tilt is a nice measure of sagittal plane balance, and C2 tilt tends to be 0. L1 pelvic angle tends to vary with PI. T4 pelvic angle tends to vary with the L1 pelvic angle. So you see here, right, a PI of 80 and a PI of 30. Their L1 pelvic angles, totally different. Their L1 tilts, actually identical, which is fascinating if you think about it. The T1 pelvic angles, totally different. T1 tilts only different by 2 degrees. Pelvic tilts off by a ton. And so if you try to define alignment by PI alone, right, and you first look at L4 to S1, the R squared 0.01 at L5 S1. It means there's no relationship between PI and L5 S1. Look at L4 to S1, 0.02. And this is exactly what the French said, looking at the developing spine. It's only once you go above L4 where you start developing some relationship, but the R squareds for those are low because it does not account for the distribution. And the graph above, PI, low PIs are the light blues, high PIs are the dark greens. You can see also that the inflection points change. Where it turns from lordotic to kyphotic can be quite low for a low PI, and it can be quite high for a high PI. So then, if you look at the L1 pelvic angle on the right here, the L1 pelvic angle, right, is the angle subtended by S1 to the femoral heads and the femoral heads to the middle of L1. The R squared is 0.6. That's pretty darn high for a one variable biological system. Those confidence bars around that, not a confidence interval, it's prediction interval, are 4 degrees on either side. So that's, I think that's almost like Mother Nature is doing us a favor, because the likelihood that you're going to nail it on the button every single surgery is very low. But if you aim for the middle and you're off by 2 or 3, you're going to be fine. And you're probably going to be fine. I shouldn't say you're going to be fine. You're probably going to be fine. And you don't need to monkey with it too much. And this L1 pelvic angle is really a measure of magnitude and distribution of lordosis. You got to remember, though, so now the goal is a C2 tilt of 0. How are we going to describe what the thoracic spine needs to be? This on the right, this stuff, this is the spline again. Here, the spline of the averages. And what you will see is that L1 and T4 tend to be pretty close to equal. T4 tends to be within 4 degrees of L1. Now, you should not go and say, okay, well, T4 is 50% of PI minus 20. That is not it. T4 is related to L1. L1 is the 50% of PI minus 20. You've got to figure out where your L1 is going to be to then describe where your T4 needs to be. Is there any evidence that anything I'm saying that this normal alignment is true? So these are the 2 graphs from, it's in press at JBJS, where we used the old ISSG database. many of the patients before we even thought about things like this. Certainly not patients that had L1 pelvic angle targets. So independent of the concept, the database independent of where we developed it. As L1PA deviates from normal, the x-axis, your risk of mechanical failure goes up, right? Pseudoarthrosis or PJK. Then the different colored bars are different T4 L1 pelvic angle relationships. So L1 pelvic angle, I think, is one way to think about the lumbosacral harmony. Did you get the lumbar spine right? And then the thoracic spine. So if you get the thoracic spine wrong, but the lumbar spine right, your risk of failure is still very high. And as you miss on both sides, your risk of failure goes up. And I think it's all, look also that this is nonlinear, right? There's a nadir there where you do okay, and overcorrection and undercorrection are both bad. The second slide is proms, which are complicated. But what it does encourage is that as your malalignment becomes worse, your proms get worse. Though in some cases it may be subtle, in part because the instruments stink. Here's the slide of all of the many different iterations that you can do. On the right side, this is L1 pelvic angle at target, T4 pelvic angle at target, the lowest risk, right? It's not zero. Your risk isn't zero. You can do all this and you can do perfect surgeries and they're still going to get failures because a fusion is wildly biologically insane. On the right-hand side here, this is a flat lumbar spine with a undercorrected thoracic kyphosis in an effort to, help them have horizontal gaze. It's almost 50-50 whether or not they're going to fail or not. And even if they don't fail, I'm willing to bet that they do incredibly poorly. I just want to add this at the end, we have very little time, is that this also brings us back to the principles. And I would encourage you guys to hop on YouTube and listen to some of Professor Duvasset's lectures about the cone of economy and how even in AIS, people achieve balance. And this goes back to something Keith Bridwell used to say when we would talk about doing, we're going to hook this up, we're going to do this, do that. And then you'd go on Bridwell's rotation and you go, don't do too much. They've been like this for a long time. You're just going to mess it up. And when we measure the L1 pelvic angle, so on the left-hand side here, this is the L1 pelvic angle in preoperative harm study group patients. The R squared is 0.6. The equation is 49% of PI minus 19. That is, for me, identical to a normal standing adult. This is at least 50-degree curves in AIS, right? Operative AIS. But that centroid on the sagittal spine is in the exact same place. I think that's very fascinating for bringing us back to this concept that Duvasset always espoused and Bridwell espouses, that these kids develop in a cone of economy and we need to not mess it up. And I will tell you that a lot, like if you go to the SRS meeting and look at a lot of the post-op derotated and straight scoliosis cases, they got TK is up here. It measures 20 degrees up here. So when you read the paper, the average kyphosis is 20 and we're, hoo-hawing, but the rest of the spine has no shape. It's totally flat. So how do we put this all together? I did all this for Larry when we started the paper and he was like, Mike, this is awesome. This is great, but you can't sell this. No one's going to buy this. You got to keep it simple. We want equations. We want categories. How do you think about this? So in general, the target lordosis for any patient is around 60% of the pelvic incidence plus 30. But you need to remember that is just a number that gives you some framework to then look at your supine CT scan and say, okay, well, this is how much they have. Now, in a ballpark, how much am I going to need to get? And then once you think of the L1 pelvic angle, 50% of PI minus 20, then you decide where to put it to achieve that L1 pelvic angle. And you may find, well, I needed 20 by the first equation Kelly told me, but if I can get 15 at 5'1", L1 pelvic angle is right. You know what? You're right. That's fine. You don't need to go for these lumbar lordosis targets. It just gives you a framework within which to think. The T4 is within 4 degrees of L1 pelvic angle. If you measure a gross discrepancy between T4 and L1 before surgery, and you think you're going to get away from it with a T10 to the sacrum, I can tell you, you are almost certainly wrong, because they are not going to go like this. What they're going to do is go like this, and they'll crumple. And that is that T10 to the failure that perhaps is even classic, like, Bob's heard it and Greg's heard it a million times. Large changes in lumbar lordosis are associated with PJK. I don't know that we have any proof for that. That's one of the studies I want to cram through ISSG this year. I think probably there are 25-degree changes when someone needed 40, or they're a wrong choice of the upper instrumented vertebra. And I think ascribing the failure to the large lordosis change is what got us into this concept of age-adjusted alignment targets.
Or they got it at the wrong spot, right, Mike? They did an L3 PSO instead of a 5.
Yeah, because it's back to magnitude.
Yeah.
But I think blaming the magnitude change is not the right answer. And so last one. This also helps objectify Rousseli, which is really difficult for people to wrap their heads around. Type 1s are rare. You can see on the right side there, the yellowy orange thing. We didn't have many in means. But if you measure the L1 PAs for the different Rousseli types, they kind of fall right on the button. And interestingly, this is also where you show the actual distribution of what T4 needs to do. So if you have a very low, as your PI goes up, T4 moves backwards. T4 tends to be a bit more forward in low PI and tends to be a little bit more dorsal in high PI. So you don't want to make a PI of 40 person have a T4 that's behind L1. You want to leave it a little bit in front and vice versa. You don't want it to be in front for high PI. You really want to start trying to pull it back and really control it. All right. I'll let you guys ask questions rather than go through all the slides.
Hey there, Kelly, can you hear me?
Mm-hmm.
Yeah, one of the questions I had is, earlier in your talk, you brought up a good point that adjacent segment disease and PJK are essentially kind of the same process. So, as young trainees, when we see this epidemic of like 4-to-1 flat back, in the decision-making process of, just addressing the adjacent level segment versus, succumbing the patient to a PSO possibly, how do we go about that in like the 50-year-old who's flat or 40-year-old that's flat? Do we do a PSO or do we just address, L3 or L3, L4?
Did Mundus put you up to this one? This came up when we were in Brazil with Juan Uribe.
No, I actually just talked about this with Hills because we did a case that we're going to go over today where.
All right, guys, we'll sign out and sign back into the other meeting. So, thanks everyone.
If it's just degenerative complaints, and he was like,
doesn't matter. It's
exactly.
It's a mechanical construct at that point.
Right.
And Juan equated it to kicking the can down the road and just do something up top and give them a couple more years and then they'll fail again when they're retired. I can tell you that in my experience that when you get them right, the patients do better. And I know Greg has told me about his experience with that. Joe Osorio told me about one that he was like, Kelly would tell me to do a PSO. He didn't do it. Patient was better. And he was like, I was right. Kelly's wrong. And then the guy broke his rods and he did the PSO. And the guy came back and like, Dr. Osorio, I was good before, but I feel awesome now. And Joe was like, there's something in it. I hate the anecdotes, but you have to experience it for yourself. For me, it was a spondylocostal dysostosis patient who he had lived his whole life with this sort of flat fusion and had this whacked out spine, but we did it. And he came back off of opioids at 6 weeks ecstatic after putting him through a PSO, as you said. I would say that if you PSOs, PSOs, I think you need to have a high volume practice. I think if you have a high volume practice for PSOs, I don't think they're that big a deal. And I think we have sort of overdone this concept of, oh, that's such a big surgery. I think you just need to get the right surgery every time. And to your point of these L4 to S1 flatbacks, it is once you understand and perhaps agree with what I say and the Europeans say, and Greg says, and maybe Bob, I don't know where Bob stands on it. He's a little bit better than me with not speaking with total authority when you could in fact be completely wrong. Is that you understand what the French call the small L5 PSO. And in the meetings, they'll talk, oh, I do a small L5 PSO. And I remember being in your shoes and being like, small PSO. PSO is like, oh my God, the OR is on high alert. Every trainee wants to be there because holy smokes, we're going to cut this person in half. But when they need 15 degrees, and that's the only way to get it, that's what you have to do. And they will do better. I am willing to bet that they will do better.
Interesting. No, thank you.
Hey, Mike, it's Hanny. I have a quick question for you. I mean, I think you don't have to be in practice for too long to understand the importance of this, but our main challenge is just trying to disseminate it to the masses. I mean, particularly given the way it changes and the rapidity with which it changes. What do you think is the best way to get this sort of knowledge base out of the purview of like 8% of spine surgeons into like 98%?
Honestly, my desire is to make a system that does it for people. I would think that most surgeons don't want to sit around and think this much about it. I want an X-ray system that measures it. You click a button and it tells you what to do. With reasoning, it can't tell you to do this surgery. We need to have the biomechanics built in, and I got to put it in the talk. I'll put it in the talk for next year about we can model shear and compression forces, and then through those you could say, well, look, you're 2 standard deviations from the normal shear at the T10, T11 disc. If you do this, it brings you back to normal, and that will lower your risk of failure, or lower your risk of reoperation, and increase your patient satisfaction. I think we just need to make it simple for people, and I think it's very doable. I don't think most people want to think about cases the way we do.
I'll add, Mike, I think there's still an absence of compelling data on the clinical side, as people are, our data is limited to 2 years. So people fail, but we blame it on their disease, and they fail outside the purview of the clinical studies for the most part. I mean, there's some studies, but they're so limited that people can excuse their lack of diligence by saying, they don't see the problem.
Yeah. I mean, that's like I mean, I make the joke, if you asked surgeons in a room who's in the lower 50th percentile of this room for surgical skill, no one would raise their hand. So when you present this stuff, they all say, well, I don't think it's a problem in my practice. But we're all like, every time we've looked at the surgeon in sight, right, in our multi-sensor stuff, kind of falls out in this concept of the master surgeon. While probably true at some end of the tail, and they're true disasters at the other end of the tail, we're all kind of the same. And our patients are still human beings and follow the same rules. But I agree, we got to get people to believe. I will say, so we validated, I know it's validated is too strong of a word, but the concept was proven true in PON from ISSG. Larry looked through all his cases this year, and I'm not sure why they didn't do L1PA, but they did the thoracic lumbar alignment relationship and found better PROMs and lower failure rates. That's on the podium this year at SRS. I'm fairly certain the Vanderbilt group has gone through theirs with Byron and Zuckerman, and also found benefits to making normal alignment. And it's all, I think L1PA and T4PA really are an effort to just objectify Rousseli, and the French and Europeans have talked about restoring Rousseli for quite some time. The ESSG did one where they looked at all of the different alignment schemes and which ones were the best, and it seemed that it was Rousseli and L1PA, which in my mind are the same thing. So it's coming out of multiple databases. It's just whether or not we can get people to listen. And ultimately, like to the question about the flat L4 to S1, we got to move away from this idea of, well, this is for deformity surgeons. We got to get each segment right at each step of the way. And if we can at least do that, reoperations will not be zero, but we can really reduce the number of gross failures in deformity, and we can reduce the number of PSOs done in the sort of revision degenerative world.
And adjacent segment disease surgery.
Yeah, I think so. Not zero, but lower.
All right, thanks, Mike.
All right,
Appreciate
have
it.
a good day, everybody.
Thank you.
Appreciate you, Mike.